Welcome, everyone. Thank you so much for joining us today. We're just going to wait a few more minutes before getting started.
What's up, everybody? Thank you so much for watching.
Welcome, everyone. We'll be getting started shortly. In the meantime, hang on tight, enjoy some of the lovely music that we're playing, and we'll get started shortly.
everybody? Thank you so much for watching. I did this medley.
Thanks everyone for your patience this afternoon. While we're waiting to get started, it would be nice to see where everyone's joining us from and where the audience is coming from. So if you want to just quickly drop your name in the chat and where you're coming from, it would be nice to hear from our audience before we get started. I'm seeing students, Abraham from Northeastern Illinois University, Northeastern as well, a lot of representation. NEIU, wow. Representing very heavily today. ChicagoCHEC, awesome. I see sisters working it out in the chat. Pacifique from NEIU, ChicagoCHEC, awesome. The Southside campus, awesome. Welcome, Monica. Welcome, everyone. Like I mentioned earlier, we are waiting to get started. I believe I see Dr. Nieves-Neira connecting. We might just have to rename him. So I'll get us started with a quick introduction while he's getting settled. So welcome to ChicagoCHEC's virtual community conversation on cervical cancer and returning to gynecological care. Thank you for joining us today for today's conversation topic. We look forward to hearing about your experiences and challenges and have brought in our expert speaker for a presentation and to answer any questions you may have. My name is Araceli Estrada. I am an Outreach Core Manager with ChicagoCHEC at Northwestern University. I'm joined today by my wonderful team to moderate today's session. I'll be doing some of the moderating at the top. You'll be seeing Alicia Kalamian during the Q&A portion, and Melissa Martinez. Please reach out if you have any Zoom issues or tech support needs.
Hello.
Hi, Dr. Nieves-Neira.
Dr. Nieves.
Hi, Dr.
Sorry.
Nieves. I'll wrap up really quickly with this intro and then you can take the floor.
Sure.
This event is brought to you by ChicagoCHEC, Cancer Health Equity Collaborative, also known as ChicagoCHEC. This is an NIH-funded grant that collaborates with Northwestern, University of Illinois at Chicago, Northeastern Illinois University, and various community partners. We aim to support cancer health equity in Chicago through research, training, education, and community engagement. We also want to give a special shout out to the Northwestern University Cancer Health Equity Research SPORE, NU-CHERS, for their support in putting this together. Before I move on to introducing our wonderful speaker, I just want to go over a few housekeeping items on the next slide. Please keep yourself on mute while others are talking. If you have any questions or comments, feel free to post them in the chat box. We'll be having a Q&A portion at the latter portion of the presentation, and a friendly reminder that we are providing Spanish interpretation. Our speaker today is Dr. Nieves. He is the chair of Gynecologic Oncology Service at the Department of Obstetrics and Gynecology at John H. Stroger Hospital of Cook County, and an associate professor at the Feinberg School of Medicine and a significant contributor to NU-CHERS. Welcome, Dr. Nieves, and take it away whenever you're ready.
Okay, great. Thank you everyone for joining us. Thank you for the opportunity to be able to speak to you. And the topic for today is about cervical cancer. And we're going to be talking about the early issues of cervical cancer and screening, determinants of health that lead to a lot of disparities, in particular for cervical cancer. And at the end, we're going to touch on the impact of the COVID-19 pandemic and the need to return to routine gynecological care to avoid a spike in cervical cancer cases. So let me share here for the slides.
I actually have the slides on the screen for you, unless I can stop sharing if you wanted to share the slides too. Either way works.
So you'll have the control?
I can do it. Just tell me when you want to go to the next slide and I'm happy to do it.
Sure. Okay, we can do it that way. All right, so next slide. I'm Wilberto Nieves, so I'm a gynecologic oncologist, board certified. Right now, my area of practice is here at the Cook County Hospital, John H. Stroger Hospital, Cook County, and the chief for the Gynecologic Oncology Service. Before that, I spent 4 years at Northwestern as an attending and researcher over there, and now changed my practice here to be able to serve our underserved communities. Okay. So no disclosures, no conflict of interest to disclose. For full disclosure, I do have participated in non-CME lecture programs sponsored by Merck for chemotherapy agents, but not saying that is relevant to this or directly linked to this presentation. Okay, next. So the overall objective is a little bit ambitious, but I think we can do it. We'll discuss HPV infection as a cause of cervical cancer. We'll talk about the most recent epidemiology of the disease, understand disparities and social determinants of health. So this is the core of your group, right? And some of the other efforts that we're undertaking at Northwestern University with our SPORE to address social determinants and disparities, other nonprofit organizations, and many of them participate in your group as well. Review the guidelines for pap smear and HPV testing for screening of cervical cancer. And then we'll talk a little bit on the impact of COVID-19 pandemic in screening for cervical cancer as well. Next slide. All right, so epidemiology and characteristics of the disease. We're going to talk about some statistics and numbers as well. Okay, next one. These are the projected numbers for 2021. So new cases, 14,500, and deaths estimated to be 4,300. Unfortunate numbers because cervical cancer is truly a disease that is preventable through HPV vaccination. It's a highly, highly effective vaccine. But as many other things in the healthcare industry and particularly in the domain of vaccination at the population level in the United States, we're way behind in HPV vaccination. And we've been hearing a lot of things and issues related to vaccination and COVID, right? I put these other numbers just to show that we haven't made a lot of progress in the last 10, even 20 years in terms of making a dramatic decrease in either new cases or deaths. So unfortunately, we have reached a plateau in the 2000s and 2010s, right, in terms of the disease itself. Next. Cervical cancer is very relevant to Illinois. We are the 5th most state with the most cases of cervical cancer. Number 1 is California, but California is a much, much bigger state, a much bigger population at 1,700 cases for 2021, followed by Texas, Florida, and New York, and then Illinois is number 5 with 560 cases, but again, a much smaller population compared to California and Texas. So it's a very important problem still for our state. Right? Overall risk for cervical cancer in the United States from birth to age 49. It's about 1 in 362, or 0.3%. So it's not necessarily the most common cancer, but again, it's still a very important one to address because it's really preventable disease through vaccination or early detection that can lead to true cures with even surgery alone. Next. These numbers are only for Caucasian population. When we look at the last 20 years or so, the light green refers to new cases. We have seen some moderate changes in the numbers. When we look at the actual incidence rates, that's a different calculation, things have been stable in the last 10 years or so. When we look at mortality, which is the dark or black line underneath, we see that pretty much since 2004, there have been no major changes. If you look at mortality rates, a 0.7% decrease for each year between 2007 and 2016. But again, not a significant improvement. This is not a home run yet. Next. So who gets cervical cancer in the US? So this number is calculated based on 100,000 women. So because the cervical cancer is specific to women, we do that calculation that way. The overall rate is 7.3 women will get cervical cancer, again, per 100,000. That number is a little lower here for 7.2 for Caucasian population. And we see that there's a major increase in the rate of cancer diagnosed for the African Americans, Black population, 8.7 per 100,000. 7.9 for American Indians, and this probably is an underrepresentation because we also have a lot of underestimation of disease among the American Indians. And the highest number, the highest group that is affected is actually Hispanics, that goes up to 9.3 cases per 100,000 women. And this starts to tell us that there are racial disparities in terms of the disease, even at the raw number level. Next. In terms of who gets the disease, this is the distribution by age. And what we see is that most cases are happening between 35 and 44, 23% of cases. So these are very young women, right? Or young mothers, young workers, young professionals. That number is followed by almost 23% again in the next 45 to 54 age group. Then when we look at the group of 55 to 64 is about 20%. So between 35 and age 64, that accounts for 2/3 of all cases. So again, these are young women or mature women that are still very important in terms of the social aspects of the population and the economic cycle as well. This is not a disease of the older women. Next. This is a percent of deaths. So we were talking about incidence, now we're talking about the deaths. And what we're seeing is that most deaths are going to happen in the group of 55 to 64. So again, these are young, still young women, right? It takes a number of years between the diagnosis, treatment, recurrent disease. So that's why we see a shift from the 40s into the 50s for the death rate to be higher. But still, 22%, 1 in 5 patients will die as early as 45 to 54, and then 13%, 35 to 44. So we have a lot of young women that are dying from this disease in the United States. On the other hand, we need to highlight that we are seeing important mortality in the older population, 65 to 75. That accounts for about 30% of deaths. We're going to touch on this a little bit later when we talk about the screening strategies. Next. So we know what causes cervical cancer, and basically it's HPV virus. And we have here a photomicrograph of the virus itself in culture. Next. That means that in terms of STIs, HPV infection is the most common sexually transmitted infection. And we estimate that 80% of women by the age of 50 will have acquired genital HPV infection. That estimates about at least 20 million people in the United States with either current or past HPV infection. But the point is that it's very, very common to be infected with HPV. Next. This is the cause of cervical cancer. There are a number of subgroups within the virus family. The ones that are most important and most problematic are 16 and 18. This is the subtype number. So 58% of cervical cancer cases are caused by HPV 16. And then when we add HPV 18, that goes up to 72%. And these are global numbers. Okay, so this is a general trend all around the world. And the importance of this number also is that with the nanovalent vaccines for HPV that we cover so many other of the subtypes listed here, the vaccine should be effective worldwide, and that's indeed what we are seeing in the actual data as well. Next. We also see that there's a temporal relationship between HPV infection and then later development of cancer. So that's another piece of information that links the HPV infection to cervical cancer. 80% of infections occur between the ages of 15 and 25. As a reminder, in the United States, 50% half of 15-year-old girls have engaged in sexual activity of whatever kind by the age of 15. So, right, most of our young women are exposing themselves to HPV infection very early. Most infections are going to go away by age 25. We have about 10% of the population that will remain HPV positive. That's when we start to see the rise in the precancerous lesions or dysplasias. And a few years later, we start to see the inflection of the curve for cancers. And we already discussed that this group of 35 to 44 has the highest rate with 23% of all the cancers. Next. Excuse me. We know that we can prevent cervical cancer, and that next is cervical cancer prevention with HPV vaccine. Next. Right now, the product that we have available, FDA approved, is Gardasil nanovalent vaccine. The first vaccine was a quadrivalent vaccine, but now we have the nanovalent. So it covers 9 subtypes. Those are listed here. 6 and 11 are mostly responsible for mild dysplasias or genital warts. All of the other ones are associated with higher risk for cervical cancer, the highest risk being 16 and 18. The vaccine is 99.5% effective against cervical cancer, including adenocarcinoma. This is important because adenocarcinomas tend to be missed by pap smear screening. So we can decrease those as well. When we look at all the other endpoints of other dysplasias like vagina, vulva, and so on, the overall protection rate for genital cancers is 97%. Next. As part of the FDA label for the vaccine, not just cervical cancers, right, but precancers or dysplasias of the vulva, vagina, and the anus. Right? 60% of anal canal cancers occur in women. And then we have to make a distinction between anal canal cancers and rectal cancers. So anus is an HPV-driven disease. In terms of men, the vaccine is licensed for the prevention of genital warts and anal cancer as well. Penile cancer is not included officially because it's such a rare cancer. But definitely there's protection against penile dysplasias or precancerous lesions. Next. And the most recent addition to the label indications for the vaccine is the prevention of oropharyngeal cancer. So these are head and neck cancers. And that was recently in July of 2020 that the USDA approved the vaccine for. So now we are covering a major spectrum of HPV-driven disease by the addition of these oropharyngeal cancers. We know that up to 80% of these cancers are HPV-16 positive. Next. So who do we vaccinate? Women and men, boys and girls. The primary target population ages 9 to 26, which was the original licensing of the vaccine. Then we have now more recently a secondary, I call it a secondary target population because we extended the age group to include women and men from ages 27 to 45. And that was officially approved by the FDA in October of 2018. When we look at this group age, 27 to 45, looking again at combined outcomes, so we're including cervical cancer prevention, vulvar, anal canal, and so on, the protection rate is 88%. So it goes down, but it's still a very significant level of protection, taking into account that most of these patients have already contracted HPV infections, right? 80% sexually active adults will have evidence of current or past infection with HPV. So even in that setting, the vaccine is still very effective. Next. Vaccination rates for HPV is a topic on its own. Overall, it remains low all across the United States. There's a number of discrepancies between southern states and northeast states. We'll touch on one example later on. Chicago, we have a little bit of a niche success story, although it's not applicable to the whole population. But there was this enterprise funded by the CDC NIH team project, and from 2013 to 2014, covering the target group of 13 to 17-year-olds, we were able to increase the vaccination rate. 3 doses is a complete regimen at that time, from 36 to 52%. Across the board in the United States, that's about the best number that we're going to reach is about 50% of the target population. In males, that was pretty dismal. The completion rate was only 18%. It was able to be increased to 26%. So, definitely progress, but definitely a lot more to do in the field of HPV vaccination. Next. All right, so screening and early detection for the disease. This is where the famous pap smear comes into play. Next. All right. So the pap smear is cytology. So we're going to be looking directly at the actual cells to see if there are abnormalities or not. The co-testing refers to HPV testing. This is a molecular test, very, very sensitive test. Molecular test to detect the presence of the virus. So this is active replication or production of the virus. And in many of the different tests, we can actually differentiate between 16 and 18 versus the other subtypes. And this category here is the important one in the sense that those are the ones that have the highest risk to progress to an actual cancer. So we would treat these patients with early colposcopy, for example. Next. The screening strategy is pretty simple. First pap smear at age 21. From there on, every 3 years, as long as they're normal, of course, until age 29. By age 30, then we start co-testing. So that refers that we're going to do both the pap smear and the high-risk HPV test. And that will be from ages 30 until 65. And as long as the tests are normal, the interval has been increased from 3 years to 5 years. So we would only have to do a pap HPV test every 5 years, as long as the testing continues to be negative, both of them, until age 65. And then by guidelines, we stop at age 65. Next. For patients that have had a hysterectomy, as long as the hysterectomy was for benign disease like fibroids, that's the most common indication for hysterectomy in the United States, or abnormal bleeding, there's no need to continue pap smears. On the other hand, if the hysterectomy was done and the patient for precancer dysplasia, or the patient has had previous high-grade dysplasia prior to the hysterectomy, then we need to continue pap smear screening up to 20 years from the date of the hysterectomy. So in some of these patients that usually get their hysterectomies in their 40s, that means that we will go beyond that age of 65 for the screening. Now, these guidelines represent a major challenge because we move away from annual pap smears, which is what most people in the community associate the gynecological visit with, to now every 5 years. So the challenge for the practitioners and the system, healthcare systems, is that we still advocate annual visits to the gynecologist or primary care provider that will provide gynecological care, and that's still recommended. So we had to dissociate this idea of patients that the only reason to go to the gynecologist is to get your pap smear, right? We need to accentuate the fact of reproductive health care, for example, or postmenopausal care, depending on the scenario. For the patient, again, that's a challenge that practices we all face. Next. The alternatives, can you hear me better? I'm getting a message. The volume is not very good.
We can hear you.
Yep, okay, okay. Alternatives to this major guideline would be if you don't have access to your HPV testing, then you could just continue with the pap smear cytology, but it would be every 3 years until age 65. A more recent development was approval of single testing with high-risk HPV tests, and that would be every 5 years between the ages of 25 to 65. Now, I have to make a comment here. We need to make sure that there are only 2 products that are FDA approved for this indication. That would be the cobas PCR test for HPV. That's a Roche product, 2014 approval. And more recently, in 2018, the assay Unclarity, and that's from Dept Dickinson. There are other providers and other tests for HPV, but they are not to be used for the 5-year screening strategy that we just discussed. Next. All right, so the older woman represents a special problem for us, right? Because the guidelines establish that you stop screening at age 65. Number one, our population is getting older and older, right? Women are living longer into their 80s, 90s. So this is a long time without further screening. We also know that most women that are diagnosed with cervical cancer have not had proper screening. About half of these patients will not have had a pap smear within the previous 5 years of their diagnosis of cervical cancer. Right? We now know that about 20 to 25% of all these cervical cancers occur in women after age 65. And we know that these women by age 65, half of them have not had a pap smear for over 10 within the previous 10 years. So most women associate that once they go through menopause, they stop their period, they don't have to go to the gynecologist. And again, half of 65-year-old patients have not had a pap smear within 10 years. So that represents a problem from the guideline point of view. Okay, next. So the overall recommendation is that in order for a practitioner to stop screening at age 65, you need to have, next slide. Yeah. You need to have the documentation of screening pap smear HPV testing for the previous 10 years. You cannot rely on the memory of the patient. 80% of the time, the patient tells you they had a pap smear within a year. That is not correct. It's more than 2 years. Or they may not even know that they had HPV testing. So the actual documentation in your record. Because we're talking about 845,000 women ages 61 to 65. So this is a big segment of the population. So we do recommend that advocate for catch-up screening until you reach those 10 years of negative documented screening. Or you may need to go over age 65 overall. Next. All right, let's touch a little bit about disparities in cervical cancer. Cervical cancer is one of the poster childs, next slide, for this problem of cervical dysplasia and cervical cancer and the association with low socioeconomic level. And since the 1970s, we have been able to recognize that low socioeconomic status is a major risk factor for cervical cancer, both the incidence as well as mortality. As you can imagine, it's a very, very complex problem, and you know this very well. Next. Overall, socioeconomic inequalities in cancer do result in increased mortality, and we know that this gap has widened over the last 3 decades. And there is substantial variation by cancer type, as we may expect, but definitely the gap has widened. The largest gaps are seen in the most preventable cancers, so that's a little bit ironic there. Now, the cancers that we can prevent the most are the ones that we see a wider gap. Okay? So, for example, cervical cancer mortality among women that live in the poor counties within the United States are twice as likely to die from cervical cancer compared to affluent counties. If we look at the example of Chicago, this is not Illinois, Chicago City. If you're Black or brown community member and you develop cervical cancer, you're 70% higher chance of dying of the disease compared to a Caucasian woman in Chicago. So a major, major disparity for us. Next. We see that there are disparities in vaccination rates. We're talking about the prevention with the vaccine. So vaccination rates are as low as 29% in Mississippi, and then can be as high as 78% in Rhode Island or the District of Columbia. So major disparities within the United States for vaccination. The highest risk groups are in the southern states, and those are the ones that have the least amount of vaccination, the lesser rate. So we anticipate, and we see this, that there's differential patterns of HPV-associated cancers across different states. Next. Let's take the example of Ohio as a case study kind of thing. So we have higher rates of cervical cancer and other smoking-related cancers, right? So smoking is much higher in the low socioeconomic levels. Smoking is a major risk factor for cervical cancer. It's as strong as the association with lung cancer. We always talk about lung cancer and being associated with smoking. Cervical cancer is just a strong association. They're more likely to present at a late stage, and their mortality is pretty much double the mortality of white women in Ohio. So 3.6 per 100,000 versus 1.6 per 100,000 Caucasian women. In terms of race, African American women are more likely to have numerous risk factors and advanced stage, so they present to us stage 3 and 4 very late. We see that every week here at Cook County, unfortunately, and less likely to undergo treatment. Okay. Okay. So multiple variables and angles that explain the low socioeconomic status association, a lack of screening, so no access to pap smear screening, HPV testing, lack of access to healthcare systems in general. So they may get a pap smear in a clinic, but then they don't get access to the more established system to get colposcopy, biopsies, and so on. They're less likely to start and complete therapy, and they're less likely to receive brachytherapy. And this has been studied, and it's clear that in African American women, there 56% are lesser likelihood of receiving brachytherapy. This is the second half of the radiation treatment, which is the most important for completing a curative intent treatment. And this has been documented in the United States for the African American women. So not just lesser access to the pap smear, but even when they get their cancer, there's still disparities in their care. Next. There was some recalculation of the mortality rates for African Americans, and basically they corrected for the number of women that have had a hysterectomy. We know that hysterectomy rates are higher in African Americans because of higher manifestation of fibroids, for example. So when they adjusted for that fat, then we found out that the mortality from cervical cancer in women, Black women, was 10.1 per 100,000 compared to Caucasian women at 4.7. So this was basically a 56% higher mortality rate in Black women. Okay? This is at the general United States numbers. Okay? So another example of what we've been talking about in terms of the disparities in presenting with later stage disease that is less likely to be cured, or also less likelihood to receive complete proper treatment. Next. All right, so let's touch bases on the impact of COVID on screening in general, and then we'll finish after this topic so we can address some of the questions. Next slide. All right, so we have been affected by this pandemic as we're going into the second year already, and everyone has been affected in a major way, right? So there was an immediate cessation of screening services during the lockdown for all diseases, not just cervical cancer, right? There was a major disruption of health services at all levels, allocation of resources and healthcare providers to take care of the large number of patients affected by COVID, social distancing measures, right? The mandate to be home pretty much during those few months of 2020, between March and May, for example. So across the nation, we saw a reduction in screening testing. So mammography numbers went down by 89%. Colorectal cancer, so these are colonoscopies, went down by 84%. That interval of 2020, we also saw a reduction in the diagnosis of new cancers by 65%. So this represents the fact that we're not recognizing, we're not diagnosing all of these cancers during the pandemic. Next. In the specific case of cervical cancer screening, similar numbers. This is Kaiser Permanente in California, so a huge healthcare system, very organized, very protocol-driven. And what you can see here, they compare screening between January and September of 2019 compared to January to September of 2020 during the actual lockdowns of the pandemic. The top graph shows the decrease in pap smear screening for women aged 21 to 29. And basically, there was a 78% reduction on the number of pap smears that were being performed compared to the previous year of 2019. As they were reaching September of 2020, there was a rebound to start improving the number of pap smears. The lower graph shows that there was an 82% reduction in women 30 to 65. So these are pap smears on HPV testing. So it was a slightly bigger impact in this group. April 2020 being the worst time, right? That was the lockdown time. And then they were experiencing a recovery by September of 2020. Now, the recovery phase, right, applies only to them. They are, again, very organized, high system, very protocol-driven, but that's not the case everywhere. Here in Australia, I can tell you that the no-show rate for even the dysplasia clinic has gone up to 50 to 70%. So it's a major problem that we're trying to deal with. So even a major system like Kaiser saw all these problems, right? And reductions in screening. Next slide. Additional barriers, loss of work, loss of income, right? Loss of insurance. We have had an influx of patients at Stroger recently because they have lost their insurance as they lost their jobs. Depletion of saving accounts, all right? So they're not able to pay for services anymore. All of these things contribute to the problem and the impact for going to the gynecologist or the primary care doctor to get their pap smears done. The other factor that we have to keep in mind is that Black and brown communities have been disproportionately affected by the pandemic, and this is precisely the same group that is on the highest risk for cervical cancer rates. So that adds to compounds the problem, right, of how we're going to restore screening services in these populations. If there is a delay of 6 months, there have been some calculations, a delay of 6 months in pap smear screening has been associated with about 10 more cases of cervical cancer in the following year. But a delay of 2 years in screening is associated with 30-something more cases per 100,000 women within the following year. When you look at it, right, we're really getting into the second year of the pandemic, and different states are being affected with secondary waves and all that. So this is a real problem that we have to work on. Next. And that's going to be a multifaceted approach, right? Address HPV vaccination. We need to increase the rates as it is. Reestablish screening testing. So we need to think about innovative approaches, maybe self-collected samples for HPV testing, so we don't have to require a visit to the gynecologist and all the issues of social distancing that we have to ensure for our patients, and therefore decrease clinic schedules, for example. Multidisciplinary approach, so gynecology, oncology, primary providers, internal medicine, family practice, pediatricians, nursing personnel, health educators, everyone, right? Hospital and clinic settings, pharmacy, community, right? So you guys are very important in this future of how we can restore screening services, nonprofit organizations, stakeholders, schools, and so on. And with that, I'll conclude here. I think I have one more slide to. I want to make sure I express my gratitude to the ChicagoCHEC initiative for this opportunity to address you and talk to you and bring some information about cervical cancer. And these are moments of constant stress, so I found that this is a good way to look at stress. Look at the positive, look backwards, and Halloween is coming up soon in a couple of days, so everyone has a nice and safe Halloween, following precautions, right? Okay, so we'll conclude with that. If there's any questions or comments?
Thank you so much for such an informative presentation today. We really appreciate you taking the time out of your busy schedule and collaborating with us for this event. So I think we can go ahead now and segue into the Q&A and open discussion section for this event. So I didn't know if anyone had, let me just see what we've got going on in the chat, if any questions have popped up in there. And if not, I know we did get some questions submitted in our registration, so I can go ahead and see what we have. So one question that came up was, are there any gene mutations linked to cervical cancer? If so, which ones?
Yeah, so for the most part, there is no a familiar inheritance pattern for cervical cancer. So, there are a number of mutations that explain what happens after HPV infection occurs, and the molecular pathways for how HPV leads to those mutations pretty well known. But I presume that the question is coming more from familiar predisposition. So no, there's no specific mutation that predisposes for cervical cancer. Cervical cancer is caused by infection with the virus, and more importantly, persistence of the virus. So 80% of infections happen between the ages of 15 to 25. By age 30, about 10% of women will have not been able to clear the virus through the immune system. It will continue to drop slowly, but by age 50, 6 to 7% of the population of women will still not be able to clear the virus. So that inability by the immune system to clear the virus away is what really drives cervical cancer.
Thank you. We had another question that came in through the registration. If a woman develops a cervical cyst, does that mean she is at a high risk for developing cancer?
cervical cysts? No. So I presume they're talking about what we call Nabothian cysts. These are cysts that are very common, particularly in women that have had children through natural birth. So Nabothian cysts are very common. They can vary in size anywhere from a couple of millimeters to 1 or 2 centimeters, but they do not predispose to cervical cancer. And then normally they do not affect the pap smear, like to give you a false negative result. That usually doesn't happen as long as the practitioner is doing the proper protocol to collect the sample.
Thank you. And then there was a similar question too regarding are vaginal cysts cancerous?
No. So vaginal cysts are not as common as the Nabothian cysts of the cervix, but they're not cancer. So you usually, and again, I don't know exactly what the person is thinking, right? Many times that there's a so-called vaginal cyst is like a fold of the mucosa, the lining of the vagina, and that's caused mostly by trauma from, again, natural birth. Those do not predispose to cancer, and they're not going to harbor cancer cells. Some women are born with some remnants from the embryological process, and those cysts can, again, be anywhere from millimeters to centimeters. Gardner's dot cyst, for example, is one of them. They can have malignant transformation, but that's extremely, extremely rare. Number one, that this kind of cyst is not common at all. And number two, the ones that is extremely rare that they would transform into malignancy.
Thank you. And then I see, hello, Robin. Robin had posted a question in the chat as well. She had said, you spoke about how we need to dissociate the idea of linking gynecological visits with pap smears. Any guidance on how we can do this?
Yeah, so this is through education, right? We had to educate our patients about what is the role of gynecological care beyond the obvious obstetrical care, right? In the younger women, they always associate the gynecologist with just having the baby, right? Obstetrical care. Then it becomes more diffuse, the understanding of what is the role of the gynecologist as a primary care doctor to help with their health, right? Contraception, right? Reproductive health in general, general health, right? From how gynecological conditions do impact general health. So this has to be education. Obviously, education at the level of the office between the practitioner, physician, or practitioner and the patient herself, but also at the community level. So we can stress more. There's not just the pap smear, but all the other things that we need to address as part of the women's health, right? And I think that speaks to all the problems that we have, right, with women's health issues, that we minimize the importance of women's health, and we kind of just put it in the bucket of pap smear and the bucket of OB care, and then nothing else happens like gynecologist. So we need to be more expansive in the understanding of how important reproductive health is for women.
Thank you. We also had another question come into the chat from Melissa. She says, thank you for this informative presentation. What might be the cause of reoccurring cervical dysplasia if repeated HPV testing is negative? Would vaccination still prevent cancers in this case? Also, pap smears were negative, but I believe that's colonoscopy detected cervical dysplasia.
Colposcopy.
Yes, thank you.
All right, so this might refer to a specific clinical scenario perhaps, but the reason why we added HPV testing is because the pap smear is not 100% sensitive to detect all dysplasias, okay? So in order to increase the detection rate, particularly in the higher risk group, which is what we discussed, 30 to 65, that's why we added the HPV testing, which is a lot more sensitive to detect the expression of the virus. Okay? Now, if we have a negative pap, but the colposcopy still detected dysplasia, that was a false negative result for the pap smear. So one way to circumvent that is, again, that we do the pap smear, the HPV testing, and that there is HPV 16 or 18 positive test, then we go to colposcopy. And 30% of the times or so, we will detect some level of dysplasia. Dysplasia is graded 1, 2, and 3. 1 is mild, 2 is moderate, 3 is severe, which is the more true precancerous lesion. Okay? The reason why there is dysplasia, recurrence of dysplasia is because, like I alluded before, there is a segment of women in the population that is not able to clear the infection. Right? We do not have a cure for the virus. So the only way that the virus goes away from the body is through immune system mechanisms. Natural immunity will eliminate 90% of infections or active infections. Like I alluded before, after age 30, 10% of women, and this is nothing of their fault, right? 10% are not able to clear that infection. That's why they have recurrent dysplasias, and that's why cervical cancer develops in that age group after the persistence of the virus. The last part of the question was whether or not vaccines are effective here. This is not an FDA official label, but we do know that vaccination has resulted in the decrease in the number of recurrent dysplasia of precancer cases, just as it has led to a decrease in the number of colposcopies. That's a test that we do looking with a microscope to find the lesions and do biopsies. So the number of biopsies, the number of colposcopies have gone down related to patients that have been vaccinated. And as an added benefit, we do see, have been able to show that indeed there is a lower rate of recurrence for patients, let's say, had dysplasia before, they get vaccinated, and now there's a lesser rate of recurrence of dysplasia. So there is a small but detectable therapeutic effect of the vaccine. But I need to stress that the vaccine is purely preventive measure. We do not have an FDA-approved or licensed vaccine for treatment of dysplasia or cancer.
Thank you, Dr. Nieves-Neira. Another question related to screening. Should older women get screened for cancer every year or every 2 years during women wellness checkups? My grandmother passed away from cervical cancer.
Yeah, so the guidelines refer to the general population, right? And those intervals of screening apply as long as both tests are negative. Once we have a positive test, whether it's an abnormal pap smear or a positive HPV test, then that's no longer routine screening. So, depending on the scenario, and there's a number of protocols that we follow, depending on the scenario and the nature of that normality, it goes anywhere from repeating the pap smear in 6 months or repeating the HPV test in 1 year. Let's say for an HPV test positive, we repeat it in 1 year. Minimally abnormal pap smear with a negative HPV test, we can repeat in 6 months or repeat it in 1 year. Or if it's more severe changes, then we do the so-called colposcopy, where we look at the cervix with a microscope. If we find a lesion, then we would do the biopsies. In those patients, then the interval of screening will be shorter. Again, depending on the scenario, maybe repeat the pap smear in 6 months and a year. If both of those continue to be negative, then they can go back to regular screening. As a GYN oncologist, I would recommend more a 3-year interval rather than a 5-year interval in someone that has had already abnormalities.
Thank you so much.
The reason why someone would die later on, at a later age from cervical cancer, is that most likely they did not have that negative 10 years of negative screening performed before the menopause or before diagnosis. Okay? 50% of women age 65 had not had a pap smear for 10 years. That's many, many years. And that's another, we were talking about the education and the understanding of what the role of the gynecologist in women's health is, that a lot of patients in the general population feel that once they go through menopause, they don't have to see the gynecologist anymore. There's no period, there's no need to see them. And that's why there's such a high rate of not proper screening with pap smears in this age group.
Thank you for that. It is 1 o'clock. We do have another question, two more questions from the audience. So the first question, how are people who might be uninsured due to immigration status or other situations be able to access screening services and cancer treatment services?
Yeah, that's a little bit more complicated question, right? Every hospital is supposed to deliver charity care, so that's one venue, right? Here at Stroger, I can speak specifically for our situation. As long as the patient is a resident of Cook County, we're able to provide all the care for dysplasia, for screening, for cancer that the patient needs, regardless of economic situation or even immigration status. That puts a major burden on our healthcare system, but that's one of the reasons why I'm here, because regardless of the ability to pay from the patient, we're unable to provide the care that the patient needs. I would advise that this patient, through some local nonprofits as well, right, that can help provide care, supplement care or income. Right now, there's a major initiative. It's called Equal Hope. It's a nonprofit organization. I'm participating in that effort as well. It's multi-institutional, so we have people from all the different major academic centers of the city of Chicago and many other stakeholders. And that's one of the things that we're trying to address, is address disparities and eliminate disparities, or at least decrease the disparities. And the main goal is to decrease the mortality rate for cervical cancer in the city of Chicago. Usually it's an issue of navigating the system, right, to be able to get to the proper scenario where we can take care of the patient.
Thank you so much. And Alicia did put the link to Equal Hope in the chat, and we'll be following up with that through a follow-up email as well.
Thank you. And I think we had one last question before we close up. I know we're over time, so we appreciate those that are staying on. Our last question is, are there any holistic measures to prevent cervical dysplasia/cancer, such as supplements or diet, for example, anti-inflammatory or intermittent fasting diet?
Yeah, I wish I could answer yes to that question, okay? We have looked at a number of nutritional parameters, because we know that malnutrition, right, is very common in our high-risk populations. We have looked at vitamin C, we have looked at folic acid, and we know that women that have higher folic acid levels are statistically less likely to have dysplasia. But when we started doing the studies where we supplement folic acid or vitamin C, or there being a number of vitamin A as well, a number of trials, those trials did not show a benefit. I know there's a number of products that are available in healthcare stores or in the internet that claim that they have the magic combination to decrease cervical dysplasia, HPV. As a physician, most of those are proprietary combinations that we don't even know what they are. And I have to say that we have not been able to prove that any of the supplements really decreases the chances of cervical dysplasia. Maybe in the future we'll be able to prove that something is indeed very important, but so far the major players that are being associated with cervical dysplasia again, when we do the studies to replace, do the replacement, they don't turn out to be positive trials. Overall, right, healthy lifestyles, healthy diet, overall use of anti-inflammatories, which I would be green vegetables and so on. And the most important really is not smoking. And the relationship between expression of HPV and smoking is very, very strong. So for vulvar cancer, if you have someone, a woman has HPV infection, let's say a normal pap smear, and she's a smoker, she's 30 times more likely to develop a vulvar cancer compared to someone that is HPV positive but does not smoke. So I cannot, underestimate the role of smoking in HPV manifestation.
Thank you so
We
much.
can keep our immune systems very healthy by exercise and some simple manipulations of the diet.
Thank you so much. I just wanted to give a big thank you to all of those that have participated with us today and joined us for this wonderful session. And thank you again, Dr. Nieves, for coming and providing all this wonderful information. We greatly appreciate your collaboration, along with the P20 with Denisha and all of our good ChicagoCHEC folks as well. Very appreciative of everybody. And I'll keep going on and thanking you guys. So I will go ahead and close us out for today. We will follow up, as Melissa said, with an email with the recordings for this event and all of that good jazz. But for now, I hope you all have a wonderful and safe holiday weekend if you celebrate Halloween and all that good stuff. But if not, either way, stay safe and enjoy. And thank you so much for coming with us today.
Thank you. Thank you for all you do for our communities. We need your help.
Thank you.
Thanks for the invitation. Bye-bye.
All right. Take care, everybody.